So now we have Dr. Ramesh KEKUNNAYA from LVPI. Another complex problem which we have to deal with is congenital fibrosis of extraocular muscles, as you can see here. And Dr. Ramesh is going to handle this complex problem for us. He will tell you what are the important findings and the management. Dr. Ramesh.
Thank you so much. Thank you so much, Dr. Sharma, for this opportunity. Yes, I will be talking about congenital fibrosis of extraocular muscles. Can I have the show of hands who see more than 5 CFEOMs per year? Less than 5? Okay. All of this, it's pretty rare. I see most of you are seeing less than 5, but some of you are not seeing also. That's why this is, strabismus is 1 to 4% of the population. I think the congenital fibrosis is total of 2% of the strabismus population. That's why it's pretty rare to see this kind of things. Sometimes you think the muscle can behave very differently. Some people can normally do this kind of tactics, and sometimes multiple things are affected. Abduction is affected, adduction, there is ptosis. Which muscle is really affected? There is some kind of aberrant innervation. And why, even if you are doing less than 5 surgeries or maybe once a year, it's important because most of these kids, it's a vision restoring surgery. It's not just a muscle alignment in terms of getting the eyes aligned. In terms of surgery, it's pretty complex. Whatever tightness, you try to release it. That's what we need to. And this comes under the typical CCDD. It's a early developmental incident, leads to specific disinnervation pattern so that they have this ophthalmoplegia. Problem is not there in the muscle, problem is there in the whole. It's not even the whole muscle, it's some of the connections there, they help to move the muscles, and during birth it does not happen. It can involve oculomotor system. Either there can be miswiring like this, or there is no wire at all. Because of this, you develop this problem. And in a short way, this is what really happens in some of the CCDDs. And these are the genes involved in the form of microtubule function. That's where they get involved. Third nerve and the fourth nerve is the most commonly involved nerves in CFEOMs. In sixth nerve palsy, Duane is there, but when it comes to CFEOMs, it's a combination of fourth and sixth nerve palsy. Imaging is important because we can go up till the level of innervation of each of this muscle and you can see. And these are some of the other rare things what you can have. And this is what in short what you can have with result with this. Just always remember lid motility and pupil. This is important when you do a third nerve palsy or congenital fibrosis. If you give importance to this, then you can differentiate whether it is type 1, type 2, type 3. I will also add two more things. One is the imaging and then the genetics. If you do three of this with the comprehensive evaluation, you are doing justice to this congenital fibrosis of extraocular muscles. Then you can come to this kind of classification. All of you know there is type 1, type 2, type 3. There are very rare variants of type 4 and type 5. Ptosis is prominent, usually bilateral, except in type 3. Primary deviation is usually hypotropic in the type 1, again because of the nerve which is involved. And type 2 is usually exotropic. There is no hard and fast rule like that. This has to be the only thing. They can have a combination of things. One important thing you need to remember is type 2 can have retinal problem and type 3 can have neurological problem you can have. And this is a very typical with the family. You can see Type 1, typically bilateral, symmetrical it is, and usually it is hypotropic eye. Eye does not even go beyond the eye. You know the nerve involved in this cases. What do you do here? There is a large exotropia, there is a large hypotropia. You have to get this exotropia corrected. Along with, you also have to generally lateral rectus periosteal fixation with the large inferior rectus with nasalization works in most of the patient. But one rule in CFEOMS is get the eye into esotropia on the table. Then your result in the long term will be much better. You can always use the imaging system to diagnose. You can see because of the misinnervation, look at the size of the muscles. All size in the sense here the third nerve is supplied, superior oblique is normal, superior oblique can be overacting. Sometimes if there is a large hypotropia, you need to do a superior oblique tenotomy, complete tenotomy as well in these patients. And this is typically type 2. They can have pupillary abnormalities. Look at the pupil. If they have some abnormality, it's type 2 most of the times. And they have a very large supralarge exotropia in this patient. Type 3 is very rare, but you need to carefully look at some kind of neurological. Just wanted to show this case. Probably a type 2 or type 3 mixture here. She has esotropia with ptosis, and this is her extraocular motility. You can see bilateral abduction limitation and also elevation. It's a combination. You can't put it. And we sent for genetic evaluation also. She had KIF2A mutation here, and what we did here is a large bilateral medial rectus recession with inferior rectus recession. You can see post-operatively she is much better. How do you determine? There is no dosage. You can say that 50 PDET, do a 6 millimeter. It doesn't work. You have to do the surgery based on the tightness which is intraoperatively. It gave a fair correction in terms of alignment, but not complete. You can still see some abnormal head posture and a mild deviation. Again, one more case. You want on the table the patient to be exotropic, then you will have this long-term outcome. And always remember, they can have a muscle abnormality. They can even have a extra bands in this kind of patient. I just want to conclude with this slide. Always remember LMP, but when it comes to CFEOMS, use imaging as well as genetic, because this will give you a complete understanding not only of CFEOMS, the spectrum of disease associated with it. Thank you so much.